Good morning, and welcome to the meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. I am Paul Casale, the chair of PTAC. As you may know, PTAC has been looking across its portfolio to explore themes that have emerged from proposals received from the public. Today, we're excited to kick off a three-meeting series of theme-based discussions on population-based total cost of care models. But first, we are honored to be joined by members of leadership at the Centers for Medicare and Medicaid Services. I am thrilled to introduce Chiquita Brooks-LaSure, Administrator of the Centers for Medicare and Medicaid Services. She oversees programs including Medicare, Medicaid, the Children's Health Insurance Program, and the Healthcare.gov Health Insurance Marketplace. A former policy official who played a key role in guiding the Affordable Care Act through passage and implementation, Administrator Brooks-LaSure has decades of experience in the federal government, on Capitol Hill, and in the private sector. And now it is my pleasure to welcome Administrator Brooks-LaSure.
Thank you so much, Paul. It's really a pleasure to join all of you today for this first physician-focused payment model technical advisory committee for PTAC public meeting of 2022. As I'm sure you're aware, our Innovation Center under the leadership of Liz Fowler, CMMI, has undertaken a complete strategy refresh of our healthcare payment and service delivery models. This includes building a deeper and more fruitful relationship with stakeholders such as yourselves. We value what you bring to the table. We want to work with you, to listen to you, and to partner with you. CMS is pursuing every opportunity to incorporate stakeholder viewpoints and perceptions, particularly those of physicians and other providers, into every phase of the development and release of new and modified CMMI models. And we hope that you'll soon notice these deeper partnerships. That's one of the reasons I'm so glad to join you today. Over the past decade, CMMI has developed and tested over 50 healthcare payment and service delivery models. But going forward, we're refreshing CMMI's strategy in order to advance value-based care. The new strategic direction is based on 5 goals, which will help ensure that every model is beneficiary-centered. They are to drive accountable care, to advance health equity, to support innovation, to address affordability, and to partner to achieve system transformation. Of course, as with everything we're doing now at CMS, we are especially concerned about that second goal, health equity, and without exception, we'll be embedding it into every CMMI model. To us, health equity means the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. We're working to advance health equity by designing, implementing, and operationalizing policies and programs that support health for all people served by our programs, by eliminating avoidable differences in health outcomes experienced by people who are disadvantaged or underserved, and by providing the care and support that our enrollees need to thrive. That means at CMS, how are we promoting health equity will always be the first question we ask, not the last. I want to ensure that our programs are operating to reduce health inequities that underlie our healthcare system. We saw this was especially necessary with our models when, in 2021, we conducted an in-depth performance review and found that health equity was not always a priority in model design, participant recruitment and selection, implementation, or evaluation. To specifically advance health equity in our models, we're doing 4 key things: developing new models, and modifying existing ones to promote and incentivize equitable care, increasing participation of safety net providers, increasing the collection and analysis of equity data, and monitoring and evaluating models for health equity impact. Overall, to achieve our new CMMI strategic direction, based on the 5 goals that I've just outlined, and our efforts to advance health equity, will be guided by 3 key principles. First, any model that CMS tests within traditional Medicare must ensure that beneficiaries retain all of the rights that are afforded to them, including freedom of choice of all Medicare-enrolled providers and suppliers. Second, CMS must have confidence that any model it tests works to promote greater equity in the delivery of high-quality services. And third, CMS expects models to achieve their reach into underserved communities to improve access to services and quality outcomes. Models that do not meet these core principles will be redesigned or will not move forward. This focus is among the reasons we announced that CMMI is transitioning our GDP model to the ACO Realizing Equity, Access, and Community Health, or REACH model. This redesign, intended to provide better care for people with traditional Medicare, addresses stakeholder feedback, participant experience, and administration priorities, especially the creation of a health system that achieves equitable outcomes through high-quality, affordable, person-centered care. At its crux, the ACO Reach model builds on CMS's 10 years of experience with accountable care initiatives, such as the Medicare Shared Savings Program, the Pioneer ACO model, and the Next Generation ACO model. It improves the GBDC. I always want to say GDP when I see that acronym. It features several new design elements and a more rigorous applicant screening process, which will ensure that participants' interests align with CMS's vision for value-based care. The new model will strive to meet the following aims: a greater focus on health equity and closing disparities in care, an emphasis on provider-led organizations and strengthening beneficiary voices to guide the work of model participants, stronger beneficiary protections through robust compliance with model requirements, greater transparency and data sharing on care quality and financial performance of model participants, and stronger protections against inappropriate coding and risk score growth. The model participants will be led by healthcare providers and require representation from patient and consumer advocates. To support equity, the ACO Reach model will specifically require participants to develop health equity plans that identify health disparities in their communities and how to address them, use innovative payments to better support care and delivery of coordination for underserved communities, collect demographic and social needs data to monitor progress in reducing disparities, and expand access to care through nurse practitioners. Beneficiaries with traditional Medicare who receive care through a REACH ACO may have greater access to enhanced benefits and certain incentives, such as telehealth visits, home care after leaving the hospital, and help with copays. Overall, beneficiaries can expect the support of REACH ACO to help them navigate an often complex health system. We're committed to continuing testing the ACO Reach model because accountable care organizations make it possible for patients in traditional Medicare to receive greater support managing their chronic diseases, to receive assistance transitioning from a hospital to their homes, and to receive preventive care that keeps them healthy. Additionally, REACH ACOs will also provide novel tools and resources for different types of healthcare providers, including primary and specialty care physicians, to improve the quality of care for people with traditional Medicare. The model will also offer providers more predictable revenue and flexibility to meet patient needs. This will allow providers to be more resilient in the face of health challenges like the current public health emergency. CMS is committed to promoting value-based care that improves the health experience for all of our enrollees, including people with Medicare, Medicaid and CHIP, and marketplace coverage through our healthcare delivery and service payment models. And we are committed to being strong partners to the providers that participate in our models. Of course, we cannot do this alone. We need you, and we look forward to future discussion and collaboration with you and all of our stakeholders. As I said in my opening of my remarks, we want to work with you, to listen to you, and to partner with you, as we very much value what you bring to the table. So with that, let me turn it over to Liz Fowler, and we will, as we continue to discuss our priorities. Liz?
Thank you, Administrator Brooks-LaSure. I really appreciate the chance to hear from you, as I'm sure everyone else does. So good morning, members of PTAC and everyone else who's participating in today's meeting. I'm really delighted to have the opportunity to speak with you again and share where CMS, the Innovation Center, is heading in terms of implementing the strategy. As the administrator just explained, last fall we launched a strategic refresh and detailed our vision for a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And while many of you already are aware and familiar with our white paper and strategy, I will take a moment just to highlight the 5 objectives, which the administrator introduced earlier, and just talk a little bit about how these are serving to guide our and prioritize our work. And then also, I think, offers a chance for us to coordinate more closely with PTAC. So the 5 priorities, first of all, starting with drive accountable care. It's really our central goal to increase the number of people in relationships with providers that are accountable for their patients' cost and improving their care. And this requires beneficiaries access to advanced primary care and ACO models that coordinate with or are integrated with specialty care to meet the full range of patient needs. And when we think about entities that can be accountable for patient care, it includes physician group practices, hospitals, other healthcare providers, Medicare Advantage plans, PACE, or even Medicaid managed care plans. And we've set a goal for ourselves that by 2030, all Medicare fee-for-service beneficiaries and a vast majority of Medicaid beneficiaries will be in a care relationship with accountability for quality and total cost. And I think here it is really relevant, the remarks and agenda that you set out for your meeting today and tomorrow to help inform some of our thinking in this area. So we're considering incentives for specialists to participate in models focused on improving the referral process, reducing unnecessary referrals, limiting low-value tests and procedures, improving communications, etc., when those services are a significant source of a specialist revenue. So how do we empower ACOs with the necessary leverage to engage specialists, given that ACOs are not able to drive volume in the same way that commercial payers can? Second, advance health equity, and the administrator spoke eloquently about the focus and importance of advancing health equity, not just for the Innovation Center, but for CMS more broadly. And as she said, we are embedding and committed to embedding equity into all aspects of our payment and service delivery models and increasing the focus on underserved populations. Stakeholders can help us understand how the Innovation Center can better collaborate with community-based organizations and other entities to increase the reach of value-based models to underrepresented and underserved populations. We want to understand more about what financial supports and payment methodologies could incentivize and sustain safety net participations and help manage risk. I also want to take this opportunity to spotlight an article published by Health Affairs last Thursday, March 3rd, titled CMS Innovation Center Launches New Initiative to Advance Health Equity, and authored by Dr. Dora Hughes, our Chief Medical Officer. It outlines the center's new initiative to advance equity in greater detail. And I also invite you to listen to a roundtable discussion on how we can support safety net provider participation in value-based care, and CMS Innovation Models. It's scheduled for Wednesday, March 16th from 1 to 3 p.m. Eastern Time. Please register and join us. The third pillar is supporting innovation. We can do more to support model participants as they look for ways to innovate care delivery approaches. And some of these supports include actionable and practice-specific data, technology, dissemination of best practices, peer-to-peer learning collaboratives, and payment flexibilities. Address affordability. In addition to our payment models, reducing expenditures in Medicare and Medicaid, our models also should have an impact on lowering patients' out-of-pocket costs. And you heard the administrator earlier this morning that this is a priority, and we'll be looking at strategies that target healthcare prices, affordability, and, as I mentioned, reduce low value or duplicative care. And finally, partner to achieve health system transformation. And this is aimed at really furthering the reach of health transformation. We need to align our priorities and policies across CMS and work in tandem with commercial payers, purchasers, states, and beneficiaries. And I think here is another area where we see possibility for collaboration and coordination more closely with PTAC. So at a core part of our strategy is creating a more streamlined model portfolio, and we are committed to having a more cohesive articulation of how all of our models fit together. The strategy provides the principles and lessons learned that'll be the basis for what we do going forward. We're prioritizing models that advance transformation via accountable care, advancing health equity and care innovations. We want beneficiaries to have a provider that is accountable in the system for providing high quality integrated care that supports patients' specific health and personal goals. So we have a long history of testing bundled payment models to drive improved quality and lower costs for episodic care, and we don't want to lose momentum from our current episode-based payment models and the care transformation that we've seen in different specialties, for example, oncology, orthopedics, cardiology, among others. However, we have realized, and it's come to a stark realization, we cannot create episode-based payment models for every specialty in silos moving forward. So I think there's a role for PTAC in really helping us think through this integration and what makes the most sense as we think about population-based total cost of care and specialty care working more hand in hand and coordinated. So we're excited that the PTAC meeting presentations and discussions planned for today and tomorrow are focused on addressing some of these very same challenges. And I just want to thank Dr. Casale and PTAC for their valued work and continued support for healthcare transformation, and thank the committee for putting together a vigorous agenda and impressive panel of experts. So thank you for your attention and best wishes for a great meeting.
Thank you, Liz, and thank you both for joining us to provide those remarks. We look forward to continuing to work with your teams. Since our public meeting last September, the committee has issued 2 reports to the Secretary of HHS with our findings on themes related to physician-focused payment models. The first was on optimizing care coordination, and the second was on addressing social determinants of health and equity. You can find our reports and other materials related to these topics, including detailed environmental scans and public comments on the ASPE PTAC website. There you can also find resources for designing payment models, including a reference guide we created on common APM approaches. Also, I'm excited to welcome 3 new members of PTAC, Dr. Larry Kaczynski, the founder and chief medical officer of Sonar MD, Dr. Walter Lin, the founder and CEO of Generation Clinical Partners, and Dr. Chinni Paluro, Senior Director of Clinical Transformation at Walmart Health. PTAC's Vice Chair, Lauren Hardin, and I welcome you. These new members were appointed by the Government Accountability Office in October and have really hit the ground running with the committee's work. I'll note that, as always, the committee is poised and ready to receive proposals from the public on a rolling basis. We currently offer 2 proposal submission tracks for submitters to offer flexibility depending on the level of detail that is available about their payment methodology. You can find information about how to submit a proposal online. As I mentioned at the outset, we're kicking off a new series of theme-based discussions today. The administrator's strategic vision for CMS includes 6 pillars. one of which is driving innovation to tackle health system challenges and promote value-based person-centered care. The Innovation Center strategic refresh includes a bold vision in which all Medicare beneficiaries with Parts A and B will be in a care relationship with accountability for quality and total cost of care by 2030. One of the goals is to increase the capacity of providers to participate in value-based models with population-based payments and total cost of care approaches. Implementing that vision involves addressing countless complexities, from definitional and structural issues to care delivery models, attribution, and benchmarking. That is why we've chosen to look across proposals submitted to PTAC and hold our first ever series on population-based total cost of care models. This series of theme-based discussions will span 3 public meetings, each on a different aspect of issues related to population-based total cost of care approaches. Today and tomorrow, we are going to focus on key definitions, issues, and opportunities related to population-based total cost of care models. We will explore which services should be included when defining total cost of care in the context of population-based models, as well as the conceptual and structural issues related to designing them. We also want to understand how to enhance provider readiness to participate in these models, another one of the Innovation Center's goals. We're particularly interested in how to structure population-based models, including the payment mechanisms, benefit design, and patient assignment. We're also curious about how future larger population-based models might relate to episode-based and condition-specific models, incentivizing coordination between primary care and specialty providers, equity implications, and opportunities for multi-payer alignment. That is a very ambitious agenda and a broad topic, which is why we will examine these issues throughout 2022. In June, we're going to focus on best practices for care delivery, improving quality and measuring the success of population-based total cost of care models. We will invite physician executives and other thought leaders to discuss care delivery innovations and improvements that have the potential to improve quality and reduce total cost of care. We'll explore performance metrics, data collection, evaluation, and the best ways to address areas like behavioral health and social determinants of health. Our September public meeting will focus on the payment considerations and financial incentives related to population-based total cost of care models. That is when we will discuss options for financing these models to incentivize care delivery improvements and provider participation. We'll also explore issues such as attribution, benchmarking, risk adjustment strategies, and moving towards downside risk. So if we don't cover a specific total cost of care topic today or tomorrow that you are interested in, you are likely to hear about it later this year. You can also read our environmental scan online, which is part of our background materials for this theme. This series of 3 public meetings will culminate in a report to the Secretary of Health and Human Services with our findings about best practices. Today, we have multiple presenters ready to describe their vision and experiences related to developing population-based total cost of care models. Then the committee will discuss what we've learned before adjourning for the day. Tomorrow, we have another set of experts giving presentations, followed by a panel discussion on definitional issues. We have worked hard to include a variety of perspectives throughout the 2-day meeting, including the viewpoints of previous PTAC proposal submitters who address relevant issues in their proposed models. We'll then have a public comment period. Public comments will be limited to 3 minutes each. If you've not registered in advance to give an oral public comment tomorrow but would like to, please email ptacregistration@norc.org. After public comments, the committee will have a discussion to shape our comments that will be included in the report to the Secretary of HHS that we will issue later this year. Finally, we'll adjourn after announcing a request for input, an opportunity for stakeholders to provide written comments to the committee on population-based total cost of care models. Taken together, the prep work, the presentations and discussions, and the public comments are aimed at informing PTAC about the latest knowledge from the field about the development of population-based total cost of care models in the context of APMs and physician-focused payment models. At this time, I would like PTAC members to please introduce themselves. Please share your name and your organization. If you would like, feel free to share a brief word about any experience you have with population-based payment or total cost of care models. Because our meeting is virtual, I will cue each of you. I'll start. I'm Paul Casale. I'm a cardiologist and Vice President for Population Health at New York Presbyterian. I lead New York Quality Care, which is the accountable care organization for New York Presbyterian, Weill Cornell, and Columbia University. Next is Lauren.
Good morning, I'm Lauren Hardin. I'm a nurse and senior advisor for the National Center for Complex Health and Social Needs and the Illumination Foundation. I've been involved in care management design for pretty much every value-based payment model that we have created across the country, and currently work on co-design of models for underserved, under-resourced, and complex populations.
Thanks, Lauren. Larry?
I'm Larry Kaczynski. I am a gastroenterologist, having practiced for 35 years. Currently, I am the Chief Medical Officer of Sonar MD, the company that I founded back in 2016. I've been involved with value-based care for the last 10 years, attempting to move my gastroenterology colleagues from fee-for-service to value-based care. I'm honored to be part of the PTAC committee and look forward to today's presentations and discussions.
Thanks, Larry. Josh?
Good morning, everyone. Joshua Lau here. I am a physician and an academic at the University of Washington in Seattle, where I studied the impact and relationship between payment models and patient and population outcomes. In addition, I'm also fortunate to provide leadership to several accountable care models that my organization is in.
Great. Walter?
Good morning. My name is Walter Lin, the founder of Generation Clinical Partners. We are a medical practice that focuses on caring for frail Medicare beneficiaries in senior living organizations, with the vision of helping these organizations, as well as medical practices like ours, transition into a world of value-based care.
Great. Lee?
Morning, I'm Lee Mills. I'm a family physician, and I previously served as Chief Medical Officer and Chief Quality Officer of 2 different accountable care organizations, and then now serve as Senior Vice President and Chief Medical Officer of Community Care of Oklahoma, which is a regional provider-owned health plan that operates in the commercial, exchange, and Medicare Advantage space, a fully capitated at-risk model for all of our lives.
Great. Chinny?
Hi, everyone. Good morning. I'm Chini Paluro. I'm a family physician by trade. I lead our clinical enterprise and care delivery for Walmart Health and manage care delivery across our underserved areas, as 80% of our stores are in underserved areas. Prior to that, I was the clinical lead of a large multi-specialty group, independent, and managed value-based care across the risk spectrum, including total cost of care delivery.
Great. Thanks, Jenny. Angelo?
Yeah, thank you. Angelo Snowplan. I'm a pulmonary critical care physician by training. Most recently was the Chief Clinical Officer for Prisma Health, where I ran a large clinically integrated network of about 5,000 physicians and was the founder and CEO of an enablement company called the Care Coordination Institute. I'm now the Chief Network Officer for a company called Upstream, which is a risk-bearing value-based company that partners with primary care docs to support them in their value-based journey.
Great. Thanks, Angelo. Bruce?
Hi, I'm Bruce Steinwald. I'm a health economist right here in Northwest Washington. Along with Paul Casale, I've been a member of PTAC for 6.5 years.
Thanks, Bruce. And Jennifer?
Hi, I'm Jenniferweiler. I'm currently the Chief Quality Officer of Metro for UC Health. I'm a tenured professor of emergency medicine at the University of Colorado, and I'm also the co-founder of UC Health's Care Innovation Center, where we partner with entrepreneurs and digital health companies to grow and scale their solutions to improve healthcare outcomes and value. I've participated in a number of groups around a migration from fee-for-service to value-based care, and I was a co-developer of a model prior to me being on the PTAC that was evaluated and approved by PTAC and considered by CMMI. I'm really looking forward to the conversation today.
Thank you. So now let's move to our first presentation. 3 PTAC members served on the Preliminary Comments Development Team, or PCDT, that has worked closely with staff to prepare for this meeting. I'm thankful for the time and effort they put into organizing today's agenda. We'll begin with the PCDT presenting some of the findings from their background materials available on the ASPE PTAC website. PTAC members, you will have an opportunity to ask the PCDT any follow-up questions afterward. And now I'll turn it over to the PCDT lead, Larry Kaczynski, and the rest of the team, Chinny and Josh.
Thank you, Paul. As the lead of the preliminary comments development team for this meeting on total cost of care, my task today is to present to you an overview of the proposals previously submitted to PTAC that included components related to population-based total cost of care. The entire team also included Chinny Paluro and Josh Lau. I'd like to begin by providing some background information. Next slide. From 2016 to 2020, PTAC received 35 stakeholder-submitted physician-focused payment model proposals. During this period, PTAC voted and deliberated on 28 of them, assessing whether they met the Secretary's 10 regulatory criteria with specific emphasis on quality and cost. Nearly all of the submitted proposals addressed their specific potential impact on cost, but 10 proposals specifically discussed the use of total cost of care measures in their payment methodology and performance reporting. This presentation provides a summary of the characteristics of the 10 selected PTAC proposals that included components related to total cost of care. It also includes additional background information on definitions and issues related to population-based total cost of care models. If you need further information, please refer to the environmental scan on population-based total cost of care in the context of alternative payment models and physician-focused payment models. Next slide. I'm now going to present a few slides of background information, first of which you see here. It's the purpose. The purpose is to emphasize that CMMI, as you have heard earlier, has set one of its goals as having every Medicare fee-for-service beneficiary to be in an accountable care relationship for quality and total cost of care by 2030. Next slide. On this slide, you see an illustration taken from a 2017 white paper by the Healthcare Payment Learning and Action Network, which established an APM framework with the goal of moving payments away from fee-for-service and into population-based payments. CMMI's statement is definitely focused on bullet B in category 4, comprehensive population-based payment models. That is not to say that condition-specific substructures cannot be nested within more comprehensive models, but our focus should be on large, comprehensive population-based models. This will require an increase in the number of healthcare providers that can participate in these accountable models, including their ability to accept downside risk. It will also require an increase in coordination between different providers, be they PCPs or specialty care physicians. Next slide. Our major focus in this meeting will be to define total cost of care. Unfortunately, there are differences in how total cost of care is currently defined across alternative payment models. PTAC is using the following working definition for defining total cost of care in the context of these models. Total cost of care is a composite measure of the cost for all covered medical services delivered to an individual or group of individuals. In the context of Medicare APMs, total cost of care typically has included only parts A and B expenditures and is calculated on a per beneficiary basis over a specified time period. This definition will likely evolve as the committee collects additional information from its stakeholders. Next slide. We'd like to show two examples of selected CMMI models where total cost of care has been defined. The first is the Maryland total cost of care model. In this model, total cost of care is defined as the aggregate Medicare fee-for-service costs for all items and services delivered to Medicare fee-for-service beneficiaries. Again, this only includes parts A and B. In the global and professional direct contracting model, now known as ACO Reach, total cost of care is defined as the average Medicare beneficiary parts A and B expenditures for aligned beneficiaries between a baseline and a performance year. Next slide. Let's look now at a definition of population-based total cost of care models. PTAC is using the following working definition of a population-based total cost of care model as a guide for focusing us during this theme-based discussion. We've defined it as a population-based alternative payment model in which participating entities assume accountability for quality and total cost of care. They receive payments for all covered healthcare costs for a broadly defined population with varying healthcare needs during the course of a year. Within this context, we are not referring to episode-based, condition-specific, or disease-specific specialty models. However, these type of models could potentially be nested within population-based total cost of care models. Again, this definition will likely evolve as the committee collects additional information from its stakeholders. Next slide. So what are the key characteristics of future population-based total cost of care models? There are areas where there appears to be general consensus. Models should facilitate accountable relationships for quality and total cost of care. They should encourage care coordination and integration of specialty care with primary care, particularly for beneficiaries with complex needs. They should improve the patient experience and their outcomes. They should facilitate identification of and sharing of best practices. They should use performance metrics, including patient-centered metrics, to incentivize quality improvements. They must focus on improving health equity. And they should align provider and beneficiary incentives. Next slide. There are areas where additional discussion is needed, though. The definition of total cost of care, which prescribes the services that are included, specifically those that are best for the patient. This is the focus of our meeting. Identification of the types of accountable entities and types of clinicians and groups that participate. The duration of an accountability period. The minimum threshold number of patients that could be included or should be included. Options for the desired care delivery model. Variations in structure of payment models. How to do patient attribution, benchmarking, risk adjustment. How to incentivize participation and facilitate transition. Not all providers are prepared to have 365-day accountability for total cost of care with two-sided risk. Encouragement of multi-payer alignment on model design components, and how to address overlap between these models, nesting, carve-outs. These all need further discussions, and I hope we will be addressing them through this meeting and the future meetings later this year. Next slide. So what potential services should be included in population-based total cost of care models? As we saw in our examples, current population-based Medicare APMs typically include accountability for only parts A and B expenditures. This typically includes professional and facility expenditures for inpatient ED and outpatient care. It usually includes provider-administered medications like biologic drugs, but not patient self-administered drugs, which can be equally as expensive. There may therefore be interest in including additional services in future population-based total cost of care models to support self-administered specialty drugs, behavioral health, long-term services, and its support, home and community-based services, and screening and referral to address social needs. These additional services would promote patient-centered care and address the social determinants of health. Next slide. So how have these components been incorporated into the 10 PTAC proposals that focused on total cost of care? We're going to discuss this now. Next slide. Let's look at the characteristics of the 10 selected PTAC proposals that included total cost of care components. At least 10 of the submitted proposals were identified as having components related to total cost of care in their payment methodology and performance reporting. One of these proposals had an advanced primary care focus. 3 had a population-specific focus. And 6 of these proposals had episode-based focus. As you can see in the table at the bottom, the 10 PTAC proposals varied by clinical focus and setting of care. 6 were only PCP focused, 7 were only specialty focused, 8 did focus on both, 6 were hospital clinic focused, 3 were in the patient home, 1 was in a skilled nursing facility, 4 were oncology related, and 3 focused on chronic or advanced illness. What we do not see are large population-based total cost of care amounts. Next slide. All 10 of these PTAC proposed models did seek to reduce healthcare costs. Common cost reduction objectives in these proposals included decreased hospitalizations and ED visits, limiting costs associated with a particular episode of care, and avoiding unnecessary services and medications. Next slide. Common cost reduction approaches in these models included improving care management and establishing financial accountability through payments with two-sided shared risk, with or without a stop-loss provision, and performance-based incentive payments contingent on quality, cost, and/or utilization of care. Next slide. Performance measures in these models varied across 3 domains: cost measures, utilization measures, and quality measures. Looking at the cost measures, many of the PTAC proposals included total cost of care for a specific group, episode, time period, or care component as a cost-specific performance measure. Additional cost measures including net savings or losses to Medicare Part A and B, and supportive and maintenance drug costs. With respect to utilization measures, all 10 of the PTAC proposals included utilization measures related to total cost of care, including the number of ED visits, ICU days, and hospital admissions, including unplanned hospital readmissions within 30 days, and then medication-related complications. Finally, looking at quality measures, all 10 of the PTAC proposals included quality measures related to total cost of care, including patient satisfaction, medication review, timeliness of care, comprehensive assessments and screening, and advanced care planning. Next slide. Let's look now at some additional background information from the environmental scan. Next slide. Various CMSMI models and other CMS programs have included relevant approaches for the development of future population-based total cost of care models. The evolution of various CMMI models and other CMS programs includes a range of approaches that can provide relevant information for developing future population-based total cost of care models. We've included them in the figure to the right. They fall into 3 categories: population-based, like MA, MSSP, ACOs, and the Maryland Total Cost of Care Model, and ACO Reach; episode-based or condition-specific, like the Oncology Care Model and BPCI; and then finally, advanced primary care, like CPC Plus and Primary Care First. Let's look at each of these categories and see how they compare with respect to the care transformation strategies, payment mechanisms, incentives around total cost of care, and finally, try to note each of their specific issues and considerations. Next slide. Starting with the current population-based model, the typical care transformation strategy was shared accountability around quality and cost. Various payment arrangements exist, from fee-for-service to capitation, but most of them are keyed to a bonus payment when costs are below threshold. Incentives are based on these performance bonuses. There have been challenges in these models. including attribution, risk adjustment, benchmarking, issues related to safety net provider participation, provider consolidation, and whether or not to include or exclude drug coverage. Next slide. Looking at the current episode-based or condition-specific models. Like the population models, the care transformation strategy in these models is also based on shared accountability around quality and cost, but for further specific episodes or conditions. The payment arrangement is typically tied to prospective payments that result in two-sided risk. This two-sided risk is benchmark-based, and there may be separate payments for care coordination. Importantly, the key here is that these models can be nested within large population-based models. Next slide. Insights from the current advanced primary care models demonstrate some differences from the other two models. The care transformation strategy for advanced primary care is largely based on patient-centered medical homes. The payment mechanism is population-based and prospective. The incentive is a positive performance-based adjustment based on a comparison with a benchmark. And the major issue here is that specialists and hospitals still operate in a largely fee-for-service system and are incentivized to deliver high-volume, high-cost care. Next slide. We would be remiss if we didn't mention insights from selected Medicaid programs. Section 1115 waiver programs use a care transformation strategy around accountable entities that use a network of providers responsible for delivering all primary care and coordinating this across the full spectrum of services. Payment mechanisms have included various payment arrangements, including episodes of care, bundled payments, shared savings, and capitation. There have been mixed outcomes regarding cost savings, but there are opportunities for multi-payer alignment, and some of these ideas could be transferable to Medicare. Next slide. There have been encouraging findings on the effectiveness of population-based approaches in improving quality and reducing total cost of care. ACOs with greater financial accountability are more likely to deliver better coordinated and efficient care for Medicare patients. Several evaluations of models that seek to reduce total cost of care have demonstrated the role these initiatives have played in reducing healthcare costs while still maintaining or improving quality of care. Some of these programs have shown success targeting higher risk, higher cost beneficiaries where there is a greater potential for reducing expenditures and utilization. Next slide. There have been challenges though. Let's look at the many challenges related to designing effective population-based total cost of care models. There's limited research exploring the relationship between total cost of care, care coordination, and health equity. There continue to be disparities in savings associated with various approaches for reducing total cost of care that vary based on a range of factors, including geographical location, patient population. Provider readiness to participate in an APM varies across the spectrum. Several evaluations of APMs that include approaches for reducing total cost of care have observed negative returns on investment. This may not be due to structural flaws, but may be due to the time necessary to generate these savings. And finally, there continue to be questions regarding the impact of voluntary versus mandatory implementation of APMs under Medicare, with mandatory models obviously posing challenges for provider engagement. Next slide. So what are the potential opportunities for improving multi-payer alignment? These include multi-layered accountability structures or established governance with multiple payer participation and representation, for example, nesting. Leveraging state-specific models to build upon existing value-based models. Providing technical assistance to ensure that commercial, Medicare Advantage, and Medicaid provider payment reforms meet the standard for Medicaid APMs and therefore qualify for bonus payment incentives. A key goal would be to bring providers panels under one set of common initiatives to align incentives, reduce administrative burden, and increase the business case for provider engagement in a meaningful delivery system reform. Some experts believe payer participation in multi-payer models can increase engagement in value-based payment models. Examples include the Maryland all-payer model, the Pennsylvania rural health model, and the Vermont all-payer model. Next slide. Our last topic surrounds areas where additional information is needed. We need broader vision regarding the structural elements of future population-based models and how they would compare to current models and programs, such as whether their payment model would be based on a fee-for-service architecture with two-sided risk or capitation. We need to define the services that are appropriate for inclusion in future population-based models in order to optimize patient-centered care. We need to investigate and define the relationship between broader population-based models and episode-based or condition-specific models which are nested within them. And very importantly, we need to figure out how to enhance provider readiness and incentivize provider participation in payment models with two-sided risk through innovative physician payment model reform, particularly for the independent physician practice and safety net providers. Finally, we need to investigate opportunities for addressing equity issues and incentivizing screening and referrals for social determinants of health. That's my last slide. For those of you who want further information on the PTAC proposals we reviewed for this presentation, I'd refer you to the appendix on total cost of care. And I would also ask my other two colleagues, Chinny and Josh, if they have any additional thoughts.
Thank you, Larry. None at this time.
Great review of our information.
Back to you, Paul.
Great. Thank you, Larry, for that very and to the whole PCDT team for a very comprehensive presentation. So we have a few minutes. I'd like to open it up to PTAC members. Any follow-up questions? That was a lot of information and really helpful. Any follow-up questions for the PCDT?
Larry, that was a tremendous presentation. Very well done. Just a follow-on question. In the research and the review, one of the things that comes up as we look at equity and integration of social determinants of health and screening is actually the financing for the services to deliver. And so I'm curious if you had conversation about that or what themes came up related to that. It's wonderful to screen and refer, but on the other side of that, the financing of those services is so important.
Well, we discussed it to a small extent, but if an entity is under total risk, then all of these other components can, in their own way, decrease the total cost of care. If you're not under a total risk-based model, it's difficult to include them.
And the components that we also touched on, and to add to what Larry had said, was that is there a way to substratify this risk and really make sure that vulnerable populations, sort of have that compensation attributed to that beneficiary, and how do we do that in a way that helps provider groups and systems fund that?
Thank you.
Other questions for the PCDT? You can either raise your hand in WebEx or simply just raise your hand and ask a question. Larry, on that slide of challenges, and I know each one of them is, it seems daunting almost, but as the PCDT discussed the challenges, did one or two sort of rise to the top of the list in terms of maybe being the most difficult to overcome as we move towards these population-based total cost of care?
I think the most significant one is how to bring the specialists into value-based care. How, PCPs have a long history of capitation and working in a value-based environment. Specialists are still paid discounted fee for service. So how to bring them into the value-based space is going to be a major, major challenge. It has to be done, though.
Agreed. Josh and Chinny, any additional comments on those challenges and thoughts?
One of the things that we spoke about, Paul, was how sort of the negative return on investment initially, and the time lag that it takes to generate savings, and therefore, most systems that run with very low margins, how do you do that front end investment? And so how do we solve for that? And especially provider-based groups.
I was just going to briefly add to the comment that Larry made, that I think how to integrate primary care and other clinicians, I think, is important, particularly when we're thinking about accountability. I think some of what we saw was, communication and connection is one thing, but that doesn't itself is, in my view, equal accountability. So that's where the kind of proverbial rubber meets the road with payment incentives and care delivery models. So I think that's really the crux of the work.
Yeah, I would agree, and I would certainly agree with all those comments. And I think understanding on who to identify as the accountable, there's often shared accountability, which can often, in some ways, unfortunately, lead to no accountability, because no one's quite said, for a particular beneficiary, we will be the accountable, or I will be the accountable. And so trying to navigate all of that, I think, can be particularly challenging. Other questions?
Paul, I have a question.
Walter, go ahead. I'm sorry.
Oh, great. Thanks.
Yeah,
all right. To be recognized. So first, Larry, Chinny, Josh, thank you so much for that really comprehensive review. Thanks also for the PTAC staff for all their assistance. My question centers around kind of whether you found any innovative physician payment models within the 10 PTAC proposals that you looked at for this presentation. Were there any ways of aligning physician behavior to achieve those outcome measures that you described during the presentation?
Well, you're going to hear of one later on this morning from me, but it's essential that providers get some type of support for this transition. So many of the commercial models are based on a shared savings at the end of a time period, but there's no investment into helping the groups make the transition. And so I think it's critical that we have to invest in order to get a return here. And the current structures of practices are not designed to succeed in value-based care. But I'm going to present something later on this morning.
That's great. So I want to once again thank you, Larry, Chinny, and Josh. This is really helpful background for our discussions today. So at this time, we have a break until 11:15 Eastern Time. So please join us then. We have a great lineup of guests for our first listening session of the day.
Produced by the U.S. Department of Health and Human Services.